to play? Yeah. Okay, so this is the stroke committee for GETAC, and let me call the roll, please. I'm here. George, you're here. Billy?
Yes, sir.
Monica? No. Lisa? Ronnie?
Here.
Deb? Warren?
Yes, sir.
Yeah. Paulina? Timothy? And Denise? Great. So I'm going to pass this down. This is everyone. This is just telephone numbers and email addresses if you can fill them in and such. Okay. To try to expedite things, we're very lucky to have GETAC here, and they're going to tell us about their stroke data collection and their regional survey. And let's see, I don't have your names. If you could just introduce yourself,
Daryl
please.
Pyle,
Yeah.
Catherine Bissell.
Daryl Pyle, Catherine Bissell.
I'm Daryl Pyle. I'm the CEO of GETAC. My background is that of a hospital administrator. For about 28 years, I was running hospitals and hospital systems. But then this opportunity came along with GETAC, and I made the move and really enjoy the job, and I really have a passion for topics like stroke and cardiac. I mentioned to you at our last meeting that I would take time to kind of do a survey of the RACs to help everyone figure out what's going on in the RACs. The task at hand was more formidable than I realized, but I started out by looking at the 4 large RACs, and that would be the RAC in the Dallas Metroplex area, STRAC in San Antonio, the El Paso RAC, and GETAC. GETAC is based in Houston. We have 9 counties. I can tell you that in trying to compare where each organization is a difficult process because they have organized their stroke programs around the unique needs and attributes of their RACs. So it's not that you can actually come up with a sentence and go see how they're handling it and they're handling it and they're handling it. There's a lot of differences between the different programs that are in place. Each have their own sophistication, and imagine each could come up here and make a very worthwhile presentation on what they're doing. Each of the RACs are working with EMS agencies in gathering data, and each RAC is interested in working together with each other to maybe come up with some commonalities and add some data or some data points that we would all have in common and word the exact same way. Sometimes just a change of 1 or 2 words in the question that they're asking providers brings different results. So that was one of the challenges as well. In total, in the first quarter, those 4 RACs studied 2,195 stroke cases, and they were reported from 63 of the 75 designated hospitals in those regions, which was an 84% reporting rate from the designated hospitals. I can tell you the registry in the Dallas RAC seems to be quite sophisticated and probably could become a model for others from a registry standpoint. During this time in Houston, we hired an RN in the past 3 months, and that is Catherine Bissell. Catherine has some terrific background as a stroke program coordinator and as just a nurse out in the field that can understand the data as it comes in and can identify when a hospital might have some data that doesn't make sense. And that's an important part of this, is you've got to look at the data and you've got to analyze it and make sure you're getting accurate data. Catherine has done that. Our board of directors about a month and a half ago looked at data that came out of our stroke committee and said, wow, this is what we've been waiting on. Now we can actually release the data to the GETAC hospitals so they can see for themselves how they compare in the area of TPA, how they compare to other hospitals. So we are blinding that data so that a hospital will only know its own data, but we're able to set benchmarks and then go and talk to hospitals who appear to be performing at a different level than their peers. Sometimes it's just a data problem. It's not necessarily that the care is good or bad, but it does take, there's value in taking time with each of them. I'd like Catherine now to share with you where we've come from on this topic in GETAC and show you the graphs that our board just approved for release to all the hospitals. Catherine.
Thank you. This is a little difficult to see, so all of you that have your computers, it's on our website, getrac.org. It's under the stroke committee. So you'll see quarter 1, 2012 statistics, and you'll find all of these graphs. So to draw attention to the first graph here, you can see on the right side of the graph, first quarter 2012, we reported 1,453 ischemic strokes. We have 29 designated stroke facilities in the GETAC region. All 29 of them submitted data for the first quarter. The bars over here on the left, the first one here is symptom onset within 2 hours. So out of those 1,453, how many presented to the emergency room within 2 hours? The other measure we're looking at is of those that presented within 2 hours, how many of them were considered TPA eligible? And then out of that, those that were considered TPA eligible, how many of them received TPA within 3 hours? The other thing is we have about 50% of our designated stroke facilities that use an expanded window of 4.5 hours. So we also looked at those measures. Of those ischemic strokes, how many of them presented within 4.5 hours? How many were deemed eligible for TPA? And how many of them received TPA? We have a couple other measures that are not on here. We actually asked for 12 reporting measures. Transfers were not on here because they're not statistically significant. And the other thing is the reasons why TPA wasn't given. And a lot of that came from we weren't getting quite enough data to pretty much make that significant. One thing I did include on here is patients that received TPA that had a significant bleed after having receiving the TPA. So I'll draw your attention to this first graph over here. Again, that's symptom onset within 2 hours. Out of 1,453 patients, only 19% or 276 patients actually made it to the ER within 2 hours. I originally thought that that was kind of dismal. When you look at the national average, it goes from 5 to 15%. So we actually pretty much, from the statistics that I can read out there on the internet, pretty much are about where we need to be. I still think it's dismal. 81% of that population is not receiving what we consider best practice care. Stroke actually is the 4th leading cause of death, and it's the 1st leading cause of disability. So that's 81% of that population that we can actually reverse with a drug that we know is efficacy, and we're not reaching them. So out of that 19%, 276 patients, we go to those that are considered eligible. So out of those 276, 52% of those were actually deemed eligible. So now we're down to 143 patients out of our 1,453 we're actually able to treat. And the reasons why they are maybe not eligible for TPA, we all know. Variety of reasons. And there's a long list, and it's justifiable why they might not be eligible. But out of that 52%, only 82% or 82% actually received TPA. And so now we're down to 117 patients that received TPA within the 3-hour time interval. So out of our 1,453 patients that that came to the emergency room that were deemed eligible, we're down to 8% of those patients that received the drug. So we have some work to do. That's what this data is showing me. We can go into the expanded 4.5-hour time window. There were some other patients that were able to be caught because they used the expanded time window. But what this data kind of showed me is I wanted to know a little bit more why. Why did we have 52% that were deemed eligible and why 82% were treated? And I apologize. I have to take this one away and pull up another one. Is this working? So the next graph we're going to look at is how we kind of blinded the data. Like Daryl had said, we were able to go to the stroke committee and we looked at some data. And if I was to just put gross numbers, how many ischemic strokes presented, we could pretty much pick out our large volume hospitals. So we had to look for a way that we could totally blind the data. And so out of those measures, they report how many ischemic strokes they had and then how many of them presented within the 2 hours. So then we looked at our eligible patient populations that received TPA within 3 hours. So you can see, so 4 or less, basically, is, and there's quite a few. You see several of them made 100%. Some of them were at 0%. Now, some of them actually gave me a reason why they didn't receive the TPA, which was reasonable. And then other ones didn't, give us some data. So where Daryl said, we can actually go out to those facilities and maybe dig a little bit deeper, ask them a few more questions. The other thing we're going to do
Less
is
than 5. Again, this is less than
5
5.
eligible. Yes, less than 5 eligible patients.
Here's the other slide that has a big grouping. You needed to find it so hospitals could win it to themselves competitively by aiming against another hospital.
And so, yeah, that's what we're doing is some of the reasons why we couldn't identify why the TPA wasn't given. We realized that some of it was in our data, and so what we're going to do is go to a web-based program to where we have to actually enter in all that information and give us more robust information for probably the next 6 months. So everything will be web-based. It'll have logic behind the reporting. So when they submit those numbers, we'll know exactly why between the 19% that were eligible, why only 52% were deemed, or out of the 19% that presented within 2 hours, why was only 52% that were deemed eligible. It'll give us some more information on that. So does anybody have questions on the volumes less than 5 or any information I've given you so far? Okay. Now we're going to go to our larger eligible patient volume. So this is 5 to 30 eligible patients that the hospital reported for the first quarter that were given TPA. As you can see, we have a larger patient population, and we've got facilities that are at 100%. Again, we want to drill that down and actually look at why we're not making those measures. We're going to work on that through the data, and we're going to work on that through the web-based reporting forms. Does anybody have any questions? Go ahead.
So the information is public on your website. Did hospitals have a strong concern to be blinded so that this information wasn't out there?
Very much so.
Okay, and so the question comes up, I mean, you have great participation with all these hospitals. What value did it have for them? How did it help them that they wanted to participate in this?
Well,
I think there's, of course, a lot of peer pressure, a lot of competition amongst hospitals. Everyone wants to be stellar. Everyone wants to show their outcomes are equally as good as their neighbor. It has been a long process. It's been a couple of years' worth of committee meetings and calling hospitals that didn't come to meetings, encourage them to come to the next meeting. But we ended up with a pretty passionate crowd, and the attendance is always really good at this particular committee. They were anxious for this to be published, but they didn't want anyone else to know who their hospital is.
And do you have an idea of how much time it required the hospital to submit and do this data submissions?
well, the feedback that I've gotten, they could pull those reports pretty readily, maybe 30 minutes for them to enter in the data each month.
And Dr. Rutledge, I think that's a real important point. If this becomes a big burden, then participation will probably decline. And one reason we've got 100% is we don't ask to pass 40 data points. We're asking like 12.
And can you list your data points that you're actually going to do?
Yeah.
On the first slide, we go back to it. We asked them to report total ischemic strokes. We asked them to report of those total ischemic strokes, how many were presented to the emergency room within 2 hours, how many were deemed eligible for TPA, and how many received the TPA within 3. And then we go to our expanded window, so we ask all 3 of those questions for 4.5 hours. How many had a significant bleed, how many were transferred, and then if they did not receive TPA, what were the reasons that they did not receive TPA. So those are our primary data points, which are pretty readily available either through an ER out of their data, or they can pull it off with some core measures I've been told.
And in your ongoing discussions, are there other data points that you've considered or not considered?
There are additional data points being considered, especially now that this is published. It raises even more questions. So I do envision it expanding based on what the committee wants to do. So it's not being required of them. They have legitimate questions. They say, well, then let's ask everybody. And I do see this expanding, but we want to keep it manageable. Otherwise, I think it's a burden, and hospitals don't have a whole lot of time to keep filling out lengthy reports.
I think the great thing that this data shows is, one, we have a huge need to educate our community. We need to get them there faster. And then also it takes it back to the hospitals. When they're looking at why we're not at 100% for giving TPA to eligible patients, that's an internal thing that we can work out with the hospitals. So even this little bit of data gives us a whole lot that we can look at for the next year's goals for our stroke committee.
That's excellent. I'm hogging all the questions. Anybody else?
Yeah, you know, when we started this was to kind of look at getting some information. And I guess the question becomes, since now we have some of this, to look at the possibility of going to the 4 regions, putting together some subcommittee to gather this data and begin to put this together for us so we can look at this, because obviously this is kind of the crux of the whole thing. This is the point of this. Overcoming the issue of hospitals wanting or not wanting to participate. I mean, that's the politics involved. But if we gather the data, then we have some good clinical information to go from. So, I mean, I think this is very helpful.
So did we interrupt your presentation? Do you have more?
Yes, sir.
So what recommendations and what have you, what recommendations do you have, and how, what do you think about this now that you've done it?
I think when you study the different racks, you'll find that everyone has a high passion for this. I think you'll also find that there's some racks that will benefit just by going this route, this simple route that we've done in Houston. And I know that RAC R has already expressed an interest in doing this, and we're just going to hand it to them. Or we'll include their data, we'll do the legwork, and there'll be a bar in our chart of comparisons. We are now able to pull in other racks. I caution you, though, on trying to prescribe this is what everybody should be doing, because each market is unique. And I laughed. I ended up frustrated with my little project for you guys because I was trying to compare like a pencil and a banana and a bicycle and a window. Everybody was so different. But everything was legitimate. I mean, they're doing great work. So that's the challenge you're going to have. Possibly you would like to come up with 2 or 3 data points that you would like to see consistently asked in all racks, and maybe that could be implemented as a next step.
And how much does this cost?
Just staff time, negligible.
And well, how much of the staff time? How much time was that? I mean, that's an empty money.
29 facilities, and so right now we're in paper reporting. So they actually give us an Excel spreadsheet, and we link those up so we can get all the aggregate data. So linking 29 spreadsheets probably 3 hours, maybe to make sure that everything, and then putting them into graphs. So maybe a day on my part, just to put everybody's data into one spreadsheet so I can look at it and analyze it, and then analyzing it and then looking at it in a different way. So I would say no more than a day for me. On a hospital part, like I said, most people tell me they can do it in about 30 minutes once they know where to pull the reports and where to pull the information. First time they got to figure out how to pull the information, but once they know it, it's not too hard.
One next step for us that is a kind of a recommendation, since you asked, we would like to see the committee integrate further with EMS agencies so that they are at the table also. because the care begins in the field, and a lot of credit is due at that point in time.
And I think some of those data points would be great for us to see on here, but I think that that's probably the next step. This little bit, the data that we have here can definitely drive some change, especially in the SETRAC region. We're already talking about a community stroke event, and we're talking about a stroke conference, just because we see needs on both sides. But as we get a little more, as we get a little farther with this data, of course, we're gonna wanna see, what is our symptom onset to CT or symptom onset to TPA? We're gonna wanna see those things. I think right now, it's just digesting the information that we have and how do we fix it from here, what can we do from here.
Right, and it could drive education as well. Hey, look, in our community, only 20% of people are coming in or calling 911. So, I mean, that could help in your RAC as well.
Dr. Rutledge?
Yep.
Would y'all be willing to kind of lead that with the 4 RACs?
Kind of lead what?
Gathering this, putting together
Well,
something?
I think we ought to discuss it because I think the idea of a RAC-centric data collection and moving up, we've already, as a committee, talked about what data points we're interested in, but we have another presentation that we're going to hear right after this that I think complements this very much as well. But I think you're right on point. This is something that we might be able to do as a committee.
It's great information. If we can get that from all 4 regions, that would be clinical.
We're definitely willing to help, but we're just one example. I think if the other regions were up here, you'd be impressed with what they're doing too.
Are there any questions from the audience?
I do have one, Doctor.
Go, please.
On your 29 facilities, were they all certified primary stroke centers?
Designated stroke.
Designated. Did you consider the other hospitals that are not?
Right now, we're just going to the designated stroke facilities.
Okay.
So the other ones can voluntarily submit their data, but it doesn't have to want. It's just designated.
Well, this is outstanding. If there are not any other questions, thank you so much. And we have this is an informational. The American Heart Association is here, and they're going to tell us about Dallas. Please introduce yourself. And
I'm Leilani Stewart. I'm one of the co-directors of the Dallas Group Grant. Just pull up my presentation here. Sure. See it on here. I'm sorry.
That's fine.
Oh, I'm sorry. So as I said, my background is an emergency room nurse, and I've been working on the Dallas Career Grant for just a little over 2 years now. To give you a little background, although this is about STEMI care, I really want to focus that this is about the coordination that we now have in Dallas County. The Dallas County Caruth Initiative is a $3.5 million grant over 2 years. We were funded by the W.W. Caruth Junior Foundation of the Communities Foundation of Texas. It is led by American Heart Association staff, and we have over 250 volunteers working on this project. We have 15 hospitals that have signed a memorandum of understanding to participate, and 24 EMS agencies across Dallas County participating in this project. We have a population of 2.4 million people, and one of the unique research metrics that we're looking at with STEMI care is the symptom onset through arterial perfusion, and we'll be looking at some of the data that we've collected in Dallas. Some of the challenges that we faced as we first started the grant is that we found that we had minimal coordination of STEMI that we collected, we are looking for the SOAR analysis. We look at onset to first medical contact time. We looked at the total EMS on-scene time, total EMS transport time. We looked at first medical contact to door, and then of course, your hospital elements, which most of you are familiar with. So this is our most recent quarter of data collection from quarter 1, 2012. It's always like 6 months behind, as quality people know. That's created for us. This is the before picture. When we started collecting data, we found out that 30% of our patients were falling out of the recommended 90-minute door balloon time. And when we think of Dallas as a metropolitan big city, we had 14 out of 15 of our hospitals were PCI capable 24/7. Still, 30% of our patients were falling out of this window, which we found out we have a lot of room for improvement in Dallas. This just shows our total patient volumes month to month, and our non-STEMI patient volumes have gone up, as you can see the trend. And STEMIs, we see about 60 to 70 STEMI patients a month across all 15 hospitals. Here's the patient age range and demographics. Our STEMIs range from 20 years old to all the way to the hundreds. Most of our patients are Caucasian males in their 50s to 60s. So when we look at our key outcome metrics, really, these are the two that I really want to highlight here is our first medical contact to balloon time. Here we have seen a 37% improvement. We've shaved off almost an hour of first medical contact to balloon time when EMS picks up the patient. We're now down to 82 minutes, which is a huge improvement. And then the second key outcome that I want to point out is really this bottom one, the door to balloon minutes saved with EMS cath lab activation from the field. We've seen a 220% improvement in this performance time. Currently, all of our EMS agencies activate the cath lab from the field, and by them activating, it's saved on average 16 minutes off of the hospital's door balloon times just by having that communication and early activation to get the cath lab team in place. I think a lot of the outcomes have to do with the education and our standardized protocols. This is where we've seen our biggest improvement in our data. So our shortest door to balloon time was 13 minutes. For last quarter, our shortest SOAR time was 59 minutes. Our average length of stay for STEMI patients in Dallas County is about 3 days. And we had 15 deaths across our STEMI non-transfer population. When we talk to a lot of the national consultants that look at STEMI care, they really, even though our mortality went up, they say not to really focus on the mortality data as much as seeing overall improvement in your key outcome metrics, because we can't affect how sick our patients are coming into the hospital, and we know that the mortality trend is going to go up and down each quarter. So this is an example of our blinded hospital data that we have for all 15 hospitals, and we rank them on the right-hand side just to provide friendly competition each quarter who had the best door to balloon time. We also take into account the patient volumes, whether they're a high or low volume hospital, seeing less than or greater than 10 STEMI patients per quarter. when we do the data analysis, it's a little bit different than how some people, we do not exclude any patients from the door to blue metric unless they were transferred into our system. So if they had a non-system reason for delay, for difficult vascular access, difficulty obtaining consent, CPR in progress, we still include these patients in the median door to blue time because we feel it's a better picture of the overall performance of the hospital. So that's why you see, well, 18% are still falling out. That's why we do not exclude any patients unless they were transfers from this measure. So what are the critical success factors that we've had in Dallas County? We really feel that we've been so successful because of the leadership and infrastructure that we set in place from the beginning. We have a Dallas stakeholder committee that really serves as a congress where we have one voting representative from each of the 39 organizations that meet together quarterly and they vote to approve any recommendations that come from the subcommittees. We have open lines of communication now that each EMS agency and hospital, we have a phone list, contact list, that if EMS wants a follow-up from a hospital, they have one phone call that they can make to get feedback on the patient. And the same with the hospitals. If they're missing a run sheet, there's one phone call that they make to the EMS agency. Typically, they get that data within 24 hours from EMS. We have had shared success. 100% of our participants have implemented standardized protocol sets, and we've rolled out a STEMI education curriculum just using paper workbooks to over 4,200 healthcare providers in Dallas County that really just focused on the process that we wanted to occur with every STEMI patient. Treat it as a trauma patient. Look at the stroke patients the same way. Identify the signs and symptoms of ACS. Do the 12 lead before anything, before vitals, aspirin, and then activate the cath lab. That is the first thing to do. Load and go. Data, data, data. We know that that matters. Every quarter we give an outstanding system performer award to the EMS agency and hospital with the fastest total treatment time. We provide media, and really that helps with the camaraderie in the friendly competition in Dallas County. We also have what you may know as false activations. We call it activations without intervention in Dallas County. We just started this. The last 2 months we've seen our AWI rates around 10%, which we feel is really good in Dallas County, that our medics are really good at interpreting EKGs, and that's why we trust them to call it from the field, pull the trigger. I had talked about the collaboration. We've had field trips where I've taken competing hospitals from competing healthcare systems to go and visit one another, sit at the table, share best practices. How are you getting these 14-minute door boom times accomplished? Everybody wanted to share their successes. They didn't want to keep it from each other because really the bottom line, it is all about the patient. We've also had 100% upgrades, equipment upgrades, where all 24 EMS agencies have the capability to transmit EKGs now.
Questions? I'll start off. So can you tell us how you think this would be applicable to stroke care?
I really think Chief Tammy Kaya from Dallas Fire Rescue, she probably said it best, that by building the communication between EMS and hospitals, it hasn't just affected STEMI care, it's affected their stroke care in the field by having better communication with the hospitals, by breaking down the walls, building trust between each other. I think if you follow that same process and improve relationships and build the collaboration, it would help with any care.
So my standard questions are always, you had $3.5 million to do this. Anybody want to give us $3.5 million? So how much time and how much money, outside of the grant, do you think this would take at this point?
We
other questions? Is anybody here from CATRAC? At the CATRAC meeting here in Austin, we were talking just about this and adding stroke data to the STEMI data because it's very similar. So I mean, I think this is, to go to George's question, I mean, this is something that we might be able to do and develop. Part of the issue is going to be money, time, getting the hospitals to cooperate, what data, you know, elements we want to collect, you know, and then how it's blinded so that hospitals will want to participate.
Well, currently, the market penetration for Action Registry, given the guidelines, there's 138 primary PCI hospitals in the state of Texas, and we have approximately 110 of the hospitals entering data into that registry. So we've almost got 100% market penetration, and that's what they're using in Houston, Austin, San Antonio, and they're creating a system report using the Mission Lifeline system report, which is very reasonable. It's about $475 for every 10 hospitals. So you could create a system report for the regions for about $2,000, which is what we're going to be doing in Dallas when the grant is over.
And to add stroke data points to that, you don't know.
You know, I can't speak for stroke, to be honest. I wish I could.
Is it AHA's interest, though, to do that, to add that to it?
Definitely would be,
Or to partner?
yes.
Put you on the spot.
Dr. Butler's what I asked before for El Paso,
Mm-hmm.
for us to become a super user for the guidelines for stroke was more expensive than for us to get Mission Lifeline reports for free.
Right, and I think that's a really good point. It is very expensive to become a user, and so that's why I was thinking this is might be more interest to us as a group because it provides the data points that we want to have to feed back to education and improvement. So it might work better for us, something along this line. Well, I hogged a lot of the questions. Anybody else want to ask or have ideas? Okay, thank you so much. Next up on our agenda is Kitten Holloway here?
Yes.
Wonderful. You're going to brief us on the results of the Cardiac Care Capabilities Survey that we sent out to the RACs. This was ostensibly to look at the transport plans and the different RACs, and very interested to see. Thank you. Okay, great, thank you.
Good morning. As Dr. Rutledge said, my name is Kitten Holloway, and I'm actually serving as the interim director for the Health Promotion and Chronic Disease section in our area. And I just want to give you a little bit of background on the information in this report. And I apologize, I don't have a lot of visuals to show you this morning. So I'll try to be very succinct in what I present to you this morning. The first thing that I want to point out is the name of this report. It's a rather lengthy title, but it really says what this report is. It is a summary of survey responses for an assessment of RAC implementation of GETAC recommendations, and those GETAC recommendations were the recommendations that GETAC had made back in 2010 as a result of a 2008 previous survey. Was GETAC had made some recommendations had made some recommendations to the RACs in regarding cardiac and stroke systems of care. And so the whole purpose of this report was to present to you what kind of information that we gathered based on the recommendations that you had made back in 2010. Most of the stroke data, this report has both stroke and cardiac data, and you will see that if you start on page 6 of the report that you have, that really has a lot of the data on the stroke systems of care. Those results are found on about pages 6 through 13. And what I wanted to do is just kind of give you some highlights of this report. And the other thing that I do want to point out is that, again, this report was, the survey was done through SurveyMonkey. 20 RACs out of 22 responded. There were about 61 total respondents, and actually on pages 4 and 5 of your report, you'll see a breakdown of that. But I think what's important for the committee to know is that this is really a reference document for you. It's not going to give you a lot of scientific findings, but what it is going to give you is some really good information about what RACs are doing based on the recommendations that you made. So what I'd like to do is share with you some of the limitations. First of all, there were 14 of the 20 RACs that responded that gave total comprehensive information. The remaining RACs gave us limited information. Some filled out more on stroke, some more on cardiac, some did not complete the survey. So there are some significant limitations to the information. The other thing that I want to point out is some of the areas that the survey actually asked about, and again related to the recommendations from the GETAC Cardiac Committee. The data was collected on RAC committee structure, purchasing methods, and specifically, obviously, on stroke and cardiac systems plans, stroke and cardiac treatment guidelines, medical oversight, regional stroke and cardiac transport plans, stroke and cardiac data collection, pre-hospital triage criteria, education, and some acute care capability criteria, and a couple of other key areas that the committee had specified. So when we looked at the survey results, in terms of the responses that we got, here are some of the highlights of what we found. 55% of RACs had an acute care committee structure. 35% of the RACs had separate stroke and cardiac committees. 44% of the RACs had a regional cardiac care system plan. And understand this is based on 20 of 22 RACs responding. 33% of RACs had developed regional cardiac care treatment guidelines, and another 33% were in development. 33% of RACs had developed a regional cardiac transport plan as a part of their regional system. And we also found that 40% of the RACs had protocols or policies that determined where STEMI patients were transported. About 33% of the RACs designated a protocol for pre-hospital identification of STEMI. And then about 73% of the RACs had assessed the availability of 12-lead ECG equipment on ALS ambulances, and of those RACs, most reported that 26 to 50% of their ALS ambulances had a 12-lead ECG equipment. I would say that overall, the one interpretation that we did have is that when we looked at and compared stroke systems with cardiac care systems, what we found is that there were 81% of the RACs had a stroke system in place versus 44% that had a cardiac care system in place. So, again, there's a lot of rich data, I think, in the report. The staff laid the report out very graphically. So you have a lot of charts and graphs to look at.
Thank you. The people have questions they want to start with.
Where are those results available for the
This report I've just given to the committee, and the committee can make it available. If the committee wants us to do something else with it, I don't know that we can put it on our website, but we can certainly look at that. That's really up to the committee and what they would like us to do.
Shouldn't the RACs have some say in that since it's our data that was collected?
I would give that question to the committee. Again, let me, a little bit more background. As you may recall, this survey was actually done in 2011, October of 2011. So the results have been hanging out there for a while. And DSHS EMS part of our department actually initiated the survey, and then the health promotion section was asked to put together the results. And that's sort of been the history of this report.
Yeah, I've been here through the whole thing.
I figured that. Right.
It's a little upsetting because it was the RACs initially at RAC Chairs before stroke meeting that said, where are those reports? We haven't seen the survey results. So it's a little concerning that information that was collected from the RACs on behalf of their facilities in EMS don't get to have access for comparative data.
Oh, I don't think anybody's, I'm certainly not saying you can't have access. I'm simply saying that the report was, is my understanding, the report was prepared for this committee, and whatever the committee so chooses to do, you know, we'll certainly follow their guidance on that.
I don't remember, was there a confidentiality when it was collected with the RACs?
That I could not tell you. My question, I guess, to the RACs would be, in the Survey Monkey, did it say anything about confidentiality? Because I haven't seen the actual survey questions. Okay. And I do apologize, I'm a little bit at a disadvantage because, as you might imagine, first of all, this report was done some time ago, and we've had some transition during that time, so I apologize if I don't have answers to some of your questions, but would certainly get those for you.
Yeah, my memory is that we put this together to try to develop best practices to share with between the RACs and stuff. At the same time, if there are RACs and people that feel like there's data is sensitive, it's not like we want to lift up anybody's skirts either. So other comments or thoughts?
Yeah, I mean, is there a concern about presenting this information? I mean,
obviously there's some.
Well, I mean, I'm not sure if I understand her question. Was she wanted it presented, or she was concerned about that information being presented?
No, I'm not concerned.
We wouldn't have given you that if it's confidential.
Okay.
Yeah.
Then,
I would not imagine so.
And I think it would be very interesting for people to see. I mean, the idea is if, I'm definitely a copy and paste kind of guy. You know, if somebody has a really good transport plan or really good ideas, to share them, you know, from rack to rack is a good idea. But also at the same time, the idea of a rack-centric stroke plan is that if you're an urban versus a rural or a frontier area, you're going to have different criteria and things that you have to do to develop for your own rack. So, I mean, I don't have issues with it, but I also want to be sensitive if other people do.
What we can do is certainly provide you with an electronic copy of this information, and that can be shared with all of your racks if you'd like us to do that.
So, go ahead.
I'd like to have the electronic copy of it.
Yeah. So, a quick straw poll. How many people would like to see this public? Everybody. Yeah. Okay. All right.
so we make a motion.
Yeah.
Pending Mr. Porter's
Please.
input from the standpoint of making this public.
Move in second. All four?
Of them.
Okay, so we'll try to make this public. Then the question is where we're going to do this, and what I'll do is I'll take this offline. We can see if we can do it with the DSHS, or we'll find some place to make it public. If nothing else, we could just, if it's electronic, we could distribute it that way as well. Because I think the RACs need to have this feedback and stuff. And if if your rack didn't submit the data, I think that should also be, we can use some peer pressure. The other question is, should we do this again sometime in the future? Like maybe like we did it in 2011, should we do it in 2016 to see how things change? I mean,
As we go to this issue of the Comprehensive Stroke Center, this is going to tie to this, because I think this becomes driven by primarily the EMS folks and things that we're going to be able to do. And then it ties back to the cardiac as well. So, I mean, the more information we can gather and provide. Okay. Sorry. What I was saying is to gather this information as we move forward. We're trying to make recommendations for the comprehensive stroke centers. I think to gather this information in a way, and it's primarily going to be driven by the EMS and the racks. So sooner, not later, I think would be better.
how much? So I'd be interested. It's always difficult to impose impose what you would like on other people's services. The racks that completed this, did you guys find this survey onerous, difficult, time-consuming to do? You have suggestions how it could be made better?
I think it would be helpful
I think it would be helpful if we're going to try to gather that data that we sit down and decide what the questions are. If I remember correctly, and my memory does not serve me well always, there were some funky questions in it that really didn't have anything to do with stroke and didn't have anything to do with cardiac. I think you alluded that there was some question about purchasing or something like that. And I can assure you, our committee chairs know squat about that. That's why they have us there, to make sure that when we're instructed to do something, we do it. So that may be one of the reasons that there's not comprehensive answers, because when my stroke chair said, I don't know how to answer that, and I said, well, I can't do the survey for you, so if you don't know the answer to the question, then don't answer it. Just move on. And I know our cardiac chair, who's a physician, was like, really? So he answered what he could, but I didn't ask them to, kill themselves over doing it. So I think we've talked before about if there is specific data we want from every rack, we want to do that. Yes, we're a little bit competitive with each other, but we are all on Team USA. So we share protocols, we share everything, we root for the other guy. So we can make those kinds of things happen if we're just part of the workings.
Other people that did the Survey Monkey, thoughts on how we could improve it, how often we do it, things like that?
Well, I'll give you a thought on how often to do it. I'm anxious to see what you've created. We're all on the same team, golly, so that kind of information does need to come out to the rack. I'm glad to hear you're doing that. Sometimes I feel like we've got people on our same team looking at us and holding little huddles here and huddles there, and no one's going to talk about what the play is. And we need to know this data. I think it's probably changed already. Let the racks look at it. Let us decide, hey, maybe we need to submit some new information, and maybe we, the racks, can do a addendum to it that brings it up to date.
How about maybe we put it on the agenda for, we distribute the data, put it on the agenda for next time, and people can discuss, what data elements or things we might do again. Because my thought is the idea would be that it's, it's to help us at a rack level. Like one of the things that in CAT-RAC that really helped us is we stole and then modified the Houston transport plan. And I bet that happened a lot, I mean, they all look alike. sound like a good idea. Yeah,
I was
George.
gonna say, Dr. Roach, would it be appropriate if I nominated someone like Ronnie to kind of, for the RAC people to have a contact person on this committee to help facilitate this process? Because
I hear a bus.
would that be appropriate, or is that?
Well, he may nominate you.
No, he's already asked politely, so I accept.
You accept? Okay, so.
It's a contact person for the committee that might help facilitate getting the ball rolling, as you said.
Dr. Rutledge?
Yeah.
One, with all the data and all the questions, and it kind of hits my mind, is as we're gathering this stuff, can we somehow get together to make sure that what the RAC chairs are asking, what everyone is asking, so we don't have 15 surveys coming out to somebody that are crossing boundaries or that are very similar? I guess trying to reduce the burden for whoever's responding from the RAC chairs, the stroke, the STEMI committee, that we can say, can we get together with somebody before we give them 27 surveys to do?
Yeah, I think that's what this is.
Okay, I just want to make sure that.
Yeah, because, I mean, we don't want to impose a bunch of work on people.
No, I just want to make sure I was getting that's where we're going, that's all.
Yeah, so
My
my thought is what we might do is Ronnie's now head of a subcommittee, contact person, and we can distribute the data, and then we can sort of then next time put together, maybe we do another survey the end of 2013 or something like that to look at best practices, how people are integrating their comprehensive stroke centers, how do we, make it, a small survey. We could use SurveyMonkey again. Does that sound like stuff people want to do? Okay.
Congratulations.
So next up, speaking about comprehensive stroke centers, I wanted to get an update. Maybe if Jane Guerrero would let us know on the certification process with the state. We made just as a reminder, our committee made a recommendation to the General Counsel, as we did with primary stroke centers, on accepting who we thought would be accepting certifying agencies by looking at them in high detail.
Yes. Yes. With the comprehensive program, we will be on our website on 9/1, we will have an updated application. Basically, it's the same application that is for the primary stroke centers. It will just have another box on it that the facility will check either primary or comprehensive, what they're applying for. That will be up September 1. We can begin accepting applications from facilities for designation October 1st. So that gives them a month lead time, and they can start applying at that time. As far as, Dr. Rutledge, you and I discussed on the primary, when we looked at expanding the rule, it said currently the rule only identifies the Joint Commission as a certifying body that we would accept. This committee looked at the two programs from the Joint Commission and DNV and gave us feedback that they were comparable programs. And so the state's position was that we would accept either certification. And that would be, this committee looked at that last time and gave us feedback that you felt that the programs were, number one, they were comparable, and number two, that they met the requirements in our rule now. So the department can accept either or certification for the comprehensive level.
Excellent. Okay, so to sort of summarize, the applications for CSCs is going to be up 9/1, and that you'll be able to start accepting the applications October 1, and that DNV or Joint Commission can be used as certification.
Correct.
Okay. Well, great. This is wonderful. Did anybody have questions about this? How many people are going to be comprehensive stroke centers?
Tough. That's going to be tough.
Be tough?
It's a good thing, right?
Yeah. 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 It's the Neurointerventional Employment Act. Are there any other things? Sorry. Are there any other things that, Jane, you want to say, any other issues or things that you have that you want to bring up?
Well, for designation, we have, y'all may or may not be aware that we've had staff turnover this summer. We had 2 designation coordinators that worked both trauma and stroke, and both of those folks went on to greener pastures. They're still alive, okay? They're just working someplace else, okay? And so we have 2 new coordinators that have joined us. Patricia Ashton Garcia and Michael Murray. Y'all here? Stand, please. So these will be your coordinators. This state is divided up. They have geographical areas that they serve, and that's listed on our website so anybody can look up who their coordinator will be in their area. So we're glad to have them, and they are already hit the ground running.
Yeah, and I'm sure you never hear this, but thank you so much for your work. I mean, you guys may have some idea, but I can tell you the amount of work they do for what they get paid and all the stuff that goes on, amazing. So I really appreciate it, and I'm sure everybody else does too, but if they haven't told you, thank you very much.
Thank you.
Okay, questions that we have, Jean? Okay, so next up yep.
For the designation? Well, I guess you could pay us twice if you'd like. It's only it's $100. Okay.
Yeah, what your question is, do you need to be both, right? So, I mean, if you're a comprehensive stroke center, you are by definition a primary stroke center because you will have met all those criteria. So my guess would be that the state would not be asking you to be certified in both. Is that
That's
cool?
correct. We would not ask you to do both. Okay.
Okay. Next up is general public comments. Anyone have any comments, suggestions, ideas? Quiet, quiet, quiet.
Can I just,
Yes.
this is on STEMI. I put some brochures out on the table as well. In Houston, we're going to have a STEMI-only conference, September the 22nd at Rice University. I've got brochures out there, and you can go to STEMIconference.org if anybody's interested in attending. If you have any questions, all the information's on the website, STEMIconference.org.
Okay, thank you. And we also have, this is a public announcement also, the Texas Brain and Spine Institute is going to have a Frontiers of Neuroscience education September 28th at College Station. Does anyone want to talk about that? Okay. Jill Taylor, and she's going to talk about, what's she going to talk about? Comprehensive review and latest treatments?
Yeah, so she's a stroke survivor.
Excellent. Any other conferences or meetings that anyone wants to talk about? Leah, you get to.
The stroke education coming out. We have one here in Austin. It's Stroke Redefining What is Possible, and it's by Seton Healthcare. We're going to have Dr. Rutledge, Dr. Grata, Dr. Stephen Warwick, Dr. Saver, so a lot of just great information. It's a 2-day symposium, all day Thursday, half day on Friday. Brochures are at the front desk, and I have some also.
Excellent. Any other announcements? Okay. Our next meeting is, what, November? Is our next meeting? And we'll rotate on the numbers dates. I don't have the exact time yet, but we'll send that out. And that's all I have, unless anybody else has anything else? Education issues, education things with EMS?
We're rocking so far, we're just.
Rocking but not ready.
Slow. Yeah.
Okay.
Slow, but it's going.
Okay, well, great. Thank you very much. That'll be the end. Oh, my pleasure.
Thank you very much.
Now you can bring it back.
Thank you.